And we're back. We have Shelbie Miller for the first time. I'm sure a lot of people listening, Shelbie, are aware of you, but people who don't know who you are or don't listen to your own podcast, can you tell us a little bit about yourself?
Yeah, for sure. First of all, thanks for having me. This is so fun. You and I go back to back when Chris was a PT student and you were leading these really informal but really good and fun journal clubs every Saturday. And you have just this gift of asking people questions. And so the fact that you get to do this for part of your job is like really fitting, in my opinion, for you. I think you're doing a phenomenal job. Super honored to be here. Super excited to just get to chat with you. But yeah, for those of you that don't know me, I'm Shelbie. I am a physical therapist out of Fort Worth, Texas. I currently split my time between TCU in the athletic training room and then in a sports medicine clinic in Arlington, Texas, which is like 20 minutes away. So I kind of get to scratch my like college and kind of pro adjacent kind of itch that I've had for a while in the TCU world. College these days is very similar to pro in a lot of ways. But then when I'm in clinic, I still get to see my high school kids and my active adults. So just have a really fun mix of patients. It's really fun. I enjoy doing it. I feel spoiled that I get to do what I get to do. As far as just kind of my like path to where I am, because I think it's important as, you know, a lot of people who desire to get into some high performance role, I think have this misconception that you absolutely have to do residency. And I don't think that's true. I think that is a very like clear path to those things, but it's not the only path. And so I guess my encouragement to people listening who want to get in those worlds, but maybe haven't gotten this residency or just from a life standpoint, it just is not in the cards for you. Know that you don't have to. I didn't. I was a student back at the clinic that I work for um, back in 2017, maintained relationships there. They knew that I was interested in getting some training room experience because I was trying to figure out if I wanted to go like NBA, WNBA route. That's still something that I'm interested in. I think long term, I just don't have a great plan for like being single with the dog as far as the travel schedule goes. So I just kind of made those desires known to the people that I worked with. Ended up getting, you know, hired on at that place. Have been with them for 7 years. It's been a great place to grow and to learn. Spent the first 5 years in a clinic role. Just had a ton of fun building relationships with our docs and our athletic trainers. I had applied to residency and didn't get in, but felt like I could create my own residency in that type of clinic. We house a residency through Texas Health Sports Medicine. So all the kind of pieces are there if you wanted to build something on your own, in my opinion. And so I did. I have spent many Friday nights doing sideline coverage with football with our doctors, our PAs, our athletic trainers. I did like the weekend sports or EMR course or whatever that you need for your SCS. Studied for my SCS, got my SCS, kind of this self-guided route. And so that was kind of one piece of my story. And then the other piece was just really being intentional with what con ed courses I was taking. I think, Chris, you and I have so many similar mentors, and you've probably heard very similar things when you were coming out of school that really kind of warned me against like, hey, don't just take a con ed course that's going to like teach you what to do, but take ones that are going to teach you how to think. Take ones that are going to give you a framework to kind of build off of. And so that's what I did. I took courses early on. I took Ben Cormack's course early on. I took Scott Morrison's optimal loading course early on. Took some like rehab to perform ones. So I didn't really take any modality heavy or like manual heavy ones early on. I really wanted to get a good framework of how to think before getting those method pieces down. So did that. It was really fun. Again, a great way to connect with people. I think courses are a super fun way to do that, super organic way to do that. And so yeah, outside of that, just really enjoy creating opportunities and trying to build relationships with people in front of me, whether that is in person at work or virtually, kind of like, you know, you did with your journal club early on. I really enjoy doing like a book club once or twice a year with people. It's just a fun way to get to know people and get other people connected to other people. I think so much of what we do is relationship based. And so the more people that you know on like a genuine level, I think that's really helpful when it comes to career stuff as well. So yeah, that's a little bit about my background, but happy to answer any other questions.
Do you want to touch on the podcast that you host, Rethink and Rehab?
Sure. Yeah, I also host a podcast. Kind of, you know, before CSM back in like 2022, I was just thinking about like, man, I'm so excited to go to CSM. Like, I'm so excited to see so many of my mentors and people that have been out doing this for 10 plus years. Because those conversations are always like so healthy and so just like, Shelbie, like when I was, you know, when I was 2 years out, I used to treat this way and now I treat it way differently, or just conversations that really revolved around how they've changed their practice. And as a new grad, that was really freeing to me to hear people that I really respected, like change their mind. I think I, for whatever reason, just kind of believe this lie that you have to really be certain and that you're not allowed to change your mind. That's not our field at all, right? It's always evolving. And so I was talking to Zach Gabor, who's a clinical athlete. He was a mentor of mine at the time. I was going through Level Up Initiative and still is, just in a different way currently. But he was like, Shelbie, we're talking about this conversation, how excited I was. And I said, what do you think about like starting a podcast where people would just come on and just share something that they've like rethought, changed their mind on, reconsidered. Like, do we feel like that's a good idea, bad idea? And he's like, no, I love that. Like, roll with it. I think that's phenomenal. He had sent me a mic months prior because we were doing some clinical athlete podcast stuff just on the side. But he was kind of like, I think this is something that you're going to do really well in. And so like, that's why I wanted to send you the mic. And they have been super supportive. Clinical athlete sponsors the podcast, Rethinking Rehab. So I don't have to do any of the boring stuff. I just get to have the conversation, then send off the audio to someone else, and they edit it, produce it, put it out. So I really just get to do the fun part, and I'm really grateful for that. It's given me a fun reason to have a lot of great people on the podcast to learn from and just chat with, and hopefully provide value to people.
Likewise. Yeah, I feel like we're in a lucky position to selfishly bring on people that we're interested
Yes.
in learning from and talking to. So
Yes.
that's why I'm stoked for this conversation. The reason I brought you on specifically was an Instagram post or reel you had a few months ago. And I think on the reel, your kind of tag was your training menu doesn't need to be complicated. And you just showed, I think it was like a lateral lunge paired with a curtsy lunge. And you were utilizing all these examples of that movement being programmed and beneficial for a variety of different rehabs. And I thought that was a great post and something that would be great for more of a long-term conversation on the podcast of the idea of a lot of rehabs can have very similar looking components and movements and exercises, but as a new grad or a student, it's maybe hard to think through actually how to implement a movement or an exercise, or that each rehab has to be super uniquely different. So I'm really excited to hear your thoughts and expand on that post or that reel that you created. I think a really good place to start is this pretty broad question of when you're prescribing a movement or an exercise in the clinic with a patient, what are all the things running through your head when you start to add in a plan of care?
Yeah, this is such a fun conversation. I think I have to certainly give credit to Zach Baker with Rehab to Perform, because I think he had a post 5, 6, 7 years ago at this point, and he posted a very similar thing and was just kind of like, it was like a snapshot of like a split squat or something. And his whole like post was basically like, name like 10 things this could be used for. And it was just kind of that same like, yeah, like this could really be used for a lot of different things. And just because something looks simple or the same doesn't mean that it has the same intention. And I think that's really important for what we do. I think that also should take some of the stress off of us as clinicians for like making things just unnecessarily complicated or fancy or circus-like. I think you do have to read the room a little bit if you're working with a super high-level athlete they maybe need something a little bit more flashy, like doing those things when it might be appropriate, even though there's not maybe a good reason to do it, just from a buy-in standpoint. But I would say 95% of the time, that's certainly unnecessary. And so for everyone else, I would say there's a few things that kind of run through my head. And I almost think of it like when you go to the eye doctor, right? And you kind of put on, is like 1 clear or is 2 clear? Okay. Is 2 or 3 clear? Okay. Is 3 or 1? That we have so many different lenses that we can kind of throw in front of us to see the problem through. And so I think the first lens that I look through is tissue healing. I think that's just from a safety standpoint. The number one thing that's going to come to mind for me is, are we safe to load tissues? Are there any tissues that I need to protect from stress? If so, what type of stress? So just as a few examples here, right? If you have someone come in that has meniscus tear along the posterior horn, or a repair in that same area, obviously early on in rehab, we're not going to squat ass to grass. We want to protect that meniscus, either injury or repair, from deep loaded compression. We also probably don't want to do like loaded rotation, right? From a shear standpoint. And so I probably am not going to have them go and just start cutting super early. I want to make sure from a tissue healing standpoint that we're far enough out where it is safe to do those things, but it's also not just a time-based decision. But that is like the first lens that I probably check things through is that. As another example, right, if you have someone with a proximal hamstring strain, maybe you want to stay away from like loaded compression and deep hip flexion angles, right? Just as examples here, that could be like your front foot elevated split squat. That could be acceleration-based running tasks, right? So things like running uphill or exploding from a ground-based position. So whether you have someone like a 3-point start or prone or supine, you probably want to stay away from that, just from the loaded hip flexion and how that would load the proximal hamstring. And so maybe we're doing more upright, A marches, A skips, those kinds of things. That actually is going to protect that proximal hamstring a little bit more. And then as a third example, right, your calf strain or Achilles repair, again, similar injuries, but obviously way different like timelines for return to sport, but same kind of principles I think apply. Early on with a calf strain, early on with an Achilles repair, I probably am not going to do explosive force production when the foot is behind the center of mass, right? So any kind of what's the word I'm looking for? Like hard start acceleration. Probably don't want to do that early on. And so that's the first ones that I look through is the tissue healing aspect. Where are we at timeline wise? Is it ready to get loaded? If it's not ready to get loaded, what do I need to like particularly stay away from? I kind of view that as that's the absolute no's. And that's like maybe the 5% that I need to stay away from. But then that really gives me like 95% to do a lot of other things. And so the second thing that probably comes to mind is what is this person's training age? I think part of that is just the setting that I'm in. You know, I have college athletes that have been doing this since they were in 7th, 8th grade. And so they just like, no, I don't really have to do a ton of coaching from a form standpoint with them. There's certainly some that I do, but for the majority, like the percent of time that I have to teach someone how to do a deadlift there versus in clinic is like significantly lower. And I love that because teaching the hinge is like low-key one of the hardest things in my opinion. And then if I go to clinic, right, and I have my middle school kid 1 hour, and then I have my 67-year-old who just had a knee replacement, and we're still working on the same thing for different reasons. Just how I communicate based on their training age and training exposure is probably going to change a little bit. So with my college athletes, I can just say, hey, we're going to do a hinge. They know exactly what I mean. It's easy peasy. My middle school kids would look at me like I had 4 eyes. If I said, okay, we're going to hinge, you're like, I don't know what that is. I've never done that. And same thing with your older folks that maybe just, or not even older, but just active adults that haven't really trained ever. They're not going to know what a hinge means. And so I might have to use different language around, we're going to bend over, we're going to bow down, we're going to try to shut a car door with your butt, like whatever cue kind of resonates with them, doing that. So not only does that inform how I communicate, but also that's going to inform just kind of my expectations for how they move, how they're going to tolerate like soreness and pain, and maybe how quickly we reload them once they're ready to get loaded. And then third thing that I consider is just, are they prepared for this activity? I think that's a super important thing is as we throw in new tasks, obviously that is going to be noise, and we need to make sure that they have been prepared for that thing so that there is a very clear thing if they start to get more symptoms, more pain, more swelling, that you're introducing things in a way that is very logical. That's going to make your job easy, right? If we start throwing in like 5 or 6 new things in the same session, we don't really know the thing that kind of drove an increase in symptoms. And so before I have someone do, for example, like change of direction is probably the most common one with a lot of our like post-op, especially like lower extremity or just like injuries in lower extremity. I want to make sure that they have prerequisite range of motion, strength, that they've tolerated some kind of plyometric to some degree. And not only that they have the tissue capacity for those things, but also the tissue tolerance, right? Those are both important pieces before introducing a particular type of load. So I know that's kind of a general thing, but I think preparation is a big key, and that really depends on what you're introducing as far as what checkpoints you want to make sure. And then the final thing that comes to mind would probably be like intensity dials. Again, I think I'm a big like visual person. So like visually, I always think of us kind of on like the soundboard as like a DJ. Like we have all these dials we have access to, and we can turn up or turn down certain things. You certainly don't want to turn up all 5 things at once, right? That's going to make your decision-making really, really complicated in my opinion. So again, going back to that change of direction example with post-operative lower extremity patients or just injured lower extremity patients, my dials that I'm considering in that moment are going to be like entry velocity, and that's going to be predicated on entry distance, right? Giving someone 5 yards to enter a cut versus 15 yards to enter a cut is naturally going to be a constraint on the system that's going to slow them down or speed them up without you even having to say anything. The second thing would be like angle of the cut. And the third thing would be whether it's predictable or not. And that's a very simplistic kind of approach to change of direction. I think for the vast majority of people, simple is good. There's obviously more nuance here than I'm communicating, but yeah, those are a few things that come to mind. But what about you? Any follow-up questions or pushback or things that you feel like you also consider? Because I'd love to learn from you as well.
Yeah, I wrote a few things down. I think all 4 of those make a ton of sense, and I agree with all of them, especially from an athlete and a like specific tissue preparation and like adaptation standpoint. For athletes or other sporting or athletic demanding related tasks, I wrote a few things down for maybe the general population, or maybe there's more of it's purely like a persistent pain, and maybe the specifics of a movement aren't as necessary and there's more of a wider spectrum. So I wrote things that I would consider, especially with like long-term programming, not only in the clinic from a movement or exercise standpoint, but from what someone can do long-term is what do they have access to? So if in the
Mm-hmm.
clinic, I'm going to try to teach them to barbell deadlift, but all they have access to is some dumbbells at their
Yeah.
house, that's going to shift maybe my trajectory of implementing things in the clinic. Or if I want them, or I think that they need to utilize free weights, but they prefer to utilize machines, then it's a different conversation. So I think access of equipment,
Mm.
I also think,
Yeah, that's great.
especially with more of these persistent pain cases, like fear of movement or concern or anxiety around an activity. And maybe long term, it's kind of to dip our toes in some of those concerning movements. But maybe early on, I'm not going to significantly or quickly expose someone to movements that they're really anxious or fearful of. And maybe there can be some pushback on that. But I think of just someone's overall like feeling of safety and confidence integrating into a movement. And then thirdly, I wrote out just their enjoyment and their goals of what to return back to. So if it's
Mm.
someone where they don't enjoy doing a movement, and I don't think it's absolutely necessary for the rehab of whatever they're coming in with, then I also want to factor in what do you want to do if we have a lot of options. So I wrote out those three, but I really like yours of the tissue healing component, those kind of absolute no's that you discussed, the person's training age or their exposure to training and their comfortability with training, their preparedness for the activity, and then kind of the intensity, like you said, dials. I think those are all great.
Yeah, I think those are also great considerations on your end. And admittedly, I don't see a ton of persistent pain, so that's like a good reminder on my end as well. So I appreciate that.
Yeah. So from there, those are the things that are some of the things that are running through your head. I wanted to get into more of like the specifics with different rehabs and what exactly this could look like. So we have different lower body rehabs, and I wanted to give you kind of an options for mock case studies or real case studies, and then upper body rehabs and how that may look different. So for a lower body rehab, what are some of these like kind of similar activities or movements that you may be adding in to accomplish a similar goal across a variety of different rehabs?
Yeah, I think there's probably three types of like buckets, I guess, that I would categorize these things into that are going to capture most of what I'm going to do. So your squat and your hinge are going to be like your two biggest repetitive things that you're going to do. Just it's a ton of variations on those two things, in my opinion. So squat and hinge, and then doing those patterns, right? Bilateral, unilateral, and then even like asymmetrical, like your split squats, your kickstand, B stands, deadlifts, squats, etc. But then also just trying to incorporate all planes of movement. Right, life does not happen just in the sagittal plane, so making sure that we are still getting frontal and transverse plane again to some degree, and those are all going to be iterations. If I do a rotational step up, that is a iteration of as a squat to a certain degree, or a hinge depending on how they're doing it, I guess. So I think those three things cover most of the bases, but then whatever tissue I'm seeing them for, right, whether that is a acute soft tissue injury or a postoperative case, I'm probably also going to do some more isolated work. So I'm glad that you mentioned the machine stuff, because I think we've probably both grown up in the era of PT where we've heard the arguments, for and against machines and whether or not they're functional, et cetera, et cetera. And I think a lot of our mentors probably echo the same sentiment that ultimately, if it's loading the tissue of interest, it is functional. So that's certainly appropriate. So yeah, I'll leave it at that, and then we can keep chatting.
Yeah, I agree with all those buckets. And it for someone maybe that has going into PT school, or they had great mentors or great clinical rotations, they have an idea from just an exercise perspective of what are these big buckets that you just discussed of a squatting pattern, a hinging pattern, bilateral stance, asymmetrical, unilateral, more of these accessory or single joint loading positions. But for clinicians and students that don't have that perspective or that knowledge base of these I don't know, buckets or these positions, it's hard for them because maybe they don't have an idea of actually where to start or tangible places. So I think for people to just have some of those like basic movement patterns in place, that can really help to identify, all right, I need to check these boxes or these positions or these movements, that if they are not familiar with that, they may just be like blindly going into the wind of choosing random activities.
Yeah. And that's, I mean, we see that, right? Anytime we have students that there's like flares of that kind of thing where you look at their session, especially early on when maybe you haven't got to give them a ton of feedback. It's just like, this is so random, but it's just like no one has sat down and like really challenged them and really helped kind of walk them through like your own thought process on when you look at session flow. Here's like why I'm starting with this thing first. And here's why I'm progressing this particular pattern in this way, right? So with like your squat, like there's so many variables with just like a squat. Like, yes, you could just do like a goblet squat, but you have to consider like depth. You have to consider the tempo. You have to consider obviously like the external load, the I guess I don't know how to say this, the freedom that you're giving them to move with certain form, right? Some people get really, really particular with how a squat looks, and some people don't super care. And there's probably a continuum of when that matters and when it doesn't. I think the closer you get to your 1RM, probably the more dialed in biomechanics probably should be, just from an efficiency and being able to produce force standpoint goes, less from like an injury standpoint. And so even like just like a simple thing like a squat, there's so many layers to just that. And then you do the same thing with the hinge, and there's so many layers with just that. And then you just start to peel back the layers and go through like, okay, here's how I would move them from a bilateral stance to maybe a asymmetrical bilateral to a unilateral, and here's why. And then here's where I would throw in rotational base movement for these reasons. And you start doing that. It's really fun to see students kind of just their eyes start to sparkle a little bit. And they're like, oh man, this is like, it's like simple, but it makes sense. But it also feels like I have some intentionality behind why I'm doing what I'm doing. And that's the same conversation that we have with our residents too. It's really fun to watch younger clinicians grow in this and really blow their mind with how simple this can and should be, but how there's also a lot of layers to it. And so that's something that I super enjoy. But yeah, it's just fun.
Yeah. So with that, you already alluded to a variety of things you could manipulate, but if you have, let's say, like an Achilles based rehab versus a knee, maybe ACL or meniscus, or a hip labral pathology, whatever it is, like you may be implementing a squat, a bilateral squat, and switching that to a split squat, or a variety of other activities. What are some similarities in those rehabs in which you're implementing some of those movements, and then maybe riffing on those differences or things you would manipulate differently?
Yeah. Yeah. So, I mean, I think, if we take your Achilles repair, your classic ACL, and maybe like a hip labral repair, like we'll just go hip, knee, ankle, they're all going to be squatting and hinging, right? For very different reasons. But I mean, again, depending on the athlete, they're having to get back to something in the weight room at some level, whether that's in high school or in college. And if they're not having to get back to the weight room, then maybe they're just doing it because they enjoy working out on their own. And if they don't even enjoy working out on their own, maybe they're just doing it because it's good for their health and their function, right? And so there's a good rationale for doing it for across the whole continuum here. I know in my world, sometimes you just have to get back to squatting and hinging because that's what is expected of you in the weight room. And maybe I would prefer to do other, unilateral based tasks because it's going to, limit the amount of compensatory strategies you have a little bit more. But you also still have to get back into the weight room with your team. And so there's a balance there as well. So just from a similarity standpoint, yeah, these are all going to look pretty similar. But I think maybe where they start to diverge a little bit, right? If we take our Achilles, repair or calf strain or whatever, something with the calf, maybe early on we're adding in some kind of like heel float variation. And I don't think that's a good long-term loading strategy. I think early on when there still is a lot of weakness, it's enough. Obviously down the road, you need to like load them up really heavy, like keep it simple. You're seated calf raise, you're standing calf raise, preferably in a deficit from a hypertrophy standpoint, put that muscle on stretch a bit. But early on, some like heel float versions, right? Like your split squat with the heel float can be a good entry point for these things, where you're still doing a split squat pattern, but you're just adding in a heel float to target that calf and Achilles a little bit more than you would if it was flat. Similarly, with maybe like an ACL, we're still going to keep our split squats in the program, but maybe the way that we're manipulating the task is a little bit different. So maybe we're throwing that front foot like elevated, the heel elevated a little bit to just encourage a more positive shin angle, increase the moment arm on the knee to increase load to that quad, if the quad is what we're after. Maybe they're not a quad tendon or a patellar tendon graft, and maybe it's more a hamstring graft. And so maybe we're actually throwing in more seated hamstring work, or maybe we're doing more of like a front foot elevated split squat to load them up from a posterior standpoint, and getting more glute and hamstring on that front leg. So it's the same movement pattern. It just kind of depends on what you're going after. And then maybe with like your hip, labral either repair or just kind of a pissed off anterior hip that is intra-articular in nature. Maybe with your split squat, maybe we're staying away from super flexion, adduction, internal rotation positions. Maybe we're not adding in any kind of, rotational component there. We're not going to the same depth that we would with maybe our ACL or Achilles tendon. But over time, that is something we want to move towards. And if we're trying to poke the bear of that hip, then maybe with that split squat, maybe we're adding in a rotation over that front leg a little bit to throw them into more flexion, adduction, IR. So the big movements all look the same. It's just like those minor tweaks that I try to make to poke the bear wherever it's necessary. So I guess that's kind of where my brain goes on the general side of things that get a little bit intentional. But then if I kind of look at more of the isolated stuff, those are going to look different as well. So with my Achilles repair, I certainly want to have calf raises in the session, probably every time, depending on how often we're seeing them. But we just want to touch base on standing, seated, different tempos for that calf and that Achilles, because it just needs it. If you've ever seen an Achilles repair, you know that these take forever and it gets so boring because there's only like a couple ways to load the calf truly. So that's why I don't get super tempted to get super fancy with my calf rehab, because you're going to underload them if you get too fancy, in my opinion. I think you get a little bit more variety early on, but yeah. So that's like one thing is more the isolated tissue loading there. And then with your ACL, depending on the graft and depending on what their numbers look like, you probably want to do some isolated knee extensions, hamstring curls, Nordics, whatever is kind of necessary there. This is kind of adjacent to the hip, but like at the training room that I'm in, we've seen quite a few like groin repairs. And so doing a lot of Copenhagen's with adductor repairs, right? Again, from just that isolated tissue loading that is needed, because we're not always going to get that direct load with more integrated tasks like a squat, hinge, etc. And then your hip labrum, maybe it's just going back and doing some like isolated hip flexion work to make sure we're not missing the mark there once it's safe to do so. I know early on that's contraindicated, but later on, definitely want to make sure they have a strong hip flexor, hip extension, hip abduction. So doing some more isolated work to address the tissues of interest, I think is also super helpful. And then I think another layer of this is just considering like what adaptations you really want. And I think, shout out to Clinical Athlete. They do a great job of this in their mentorship, but really considering what qualities you're trying to train so that your dosage reflects that. And so I guess I'm just sharing this kind of as a reminder that if you're trying to get range of motion versus hypertrophy versus peak force expression versus rate of force, like that should be reflected in your programming, and that will look a little bit different. So it just adds like another layer of this. Just when you think you get bored with like a squat, well, now you need to add in like a different form of dosing to get a different type of quality that you're after. So that's what I got right now.
Yeah, I like all of that. And maybe to someone new to this, it maybe sounds like too much, or it may be feeling like it's paralyzing. But I think if you have these big buckets of movement patterns, if you know what tissues are currently needing to be rehabbed or that need to be protected, whatever it is, then you can start to build out a plan. And then to your point of like, what are some of these physiological adaptations outside of the movement options, then that can bias the volume, the intensity, the rate of force, the constraints you're adding, whatever it is. But I think summarizing, a lot of the foundational movements will be in a lower body plan, different squatting variations, different hinging variations, different asymmetrical stances, but we may shift some of the load, the positioning, the tempo, the constraints to bias maybe a little bit more of one area versus another, or offload a little bit of an area versus another. But a lot of times it's still a different squat pattern or similar squat pattern. It's a step up, etc. And then to your point, more of these specific local tissue adaptations with more isolated loading in an area of an Achilles or calf versus a knee and a quadriceps or a hamstring or a hip. And that also, if depending on the resources of the clinician, of the athlete, the time availability, let's say it's an Achilles repair. If the athlete and the patient and the clinician has time, maybe they are doing other isolated work at the quads, at the hamstrings, at the hips, because we know there's probably going to be other kind of detraining and atrophy effects down that whole surgical limb. Mm-hmm. But as a non-negotiable, there should be at least some isolated calf loading and Achilles loading and some of these more compound, comprehensive, integrated movements. And then all the other stuff should still be a discussion, knowing that with these longer term, either non-operative or post-operative rehabs, we still need to train the entire leg and system, and that needs to be integrated as a whole as well, even if it's not done in the clinic.
Yeah, no, absolutely. And I think it can be tempting to want to like change it up, because as a clinician, sometimes you can get bored, especially like your Achilles repairs where you're like, oh my gosh, it has been 4 months and we still are just doing so much strength work. We just haven't even gotten to a place where we can do jumping yet. It can be tempting to want to change it up as a clinician because you get bored. But yeah, I guess it's just a reminder, like stay the course, do the simple things well. Eventually it will pay off. But yeah, I think simple is not always received super well. Like I remember a classmate in PT school, he went to, and I've told Jared Hall this, so this shouldn't be new information, but I've told Jared Hall, like he went to go like hang out with him and like shadow him when we were students. And he came back and he's like, all Jared does is like exercise people. And he was just like so disappointed that it was like so simple and that he wasn't doing like a ton of, crazy manual or crazy fancy exercises. And I remember as a student, before I got corrupted, I was just like, man, like, yeah, that's like interesting. And now knowing Jared, it like makes a lot of sense. And now I'm very similar. I think if a student were to come shadow me, they would in some ways feel like it was pretty simple. But I think when you start to take the layers or appreciate the layers here, it adds a necessary layer of intention, and it is complex, but we don't need to make it more complex than it is.
Yeah, I'm glad you touched on that. And that like almost self-consciousness that you may feel as a clinician of, oh, does this patient or does this athlete think I'm not doing a good job, or are they getting bored and I need to change it up because I need to satisfy them, or they think that I'm not being progressive enough with the plan, whatever it is. But if you're clearly setting those expectations of this is why we're doing this is why we're holding off, this is why we aren't doing these other things, this is when I would introduce these other things, whatever it is, whether it's running, plyometrics, et cetera, this is why we're not doing all these other drills, then, and your level of confidence as a clinician, that should just instill to the athlete and patient, okay, there's a process, I know what to do, even though it may be relatively homogenous and somewhat stale, like these are the things that will move me forward, and there's the momentum. And that's hard to express and portray and feel as a newer clinician. And you're thinking, we've done calf raises for like 5 months and we're not doing that many other things. But if you know what the end goal is, kind of what your objective criteria is to get to the next things, then the value of what you're doing, and you don't need to feel kind of neurotic around switching out the plan every few sessions.
Yeah, you don't have to crash out when you're like, I'm just tired of this.
Yeah.
But totally. You bring up a really good point, Chris. I think for the athlete, it's really, really helpful when you do objective testing. Obviously, we should all be doing that, but I think there's certainly cases where we could all be doing better. But for someone like an Achilles, where it's just a long grind, but if they know, hey, every 4 weeks, we're testing your strength, and once we get to this metric, then we're going to do this. When they can at least like see that there is plan and that there's decisions being made off the testing that you're doing, I think that does help, at least to a certain degree, keep them engaged. If they know every 4 weeks, the same thing with their ACLs, right? Every time we test them, they're like, how's my numbers? Are they better? Are they worse? What's my difference leg to leg? So they get bought in when they start to see that as well. And then they know that you as a clinician, you're taking that information, actually doing something with it. And that to a certain degree, like these new things have to be earned. And that's not us being mean or us trying to be like egotistical. It's just like we're trying to look out for you and you can't look out for yourself. And so we have to hold to some objective thing, even if you feel like you could, even if you want to. Sometimes we just have to protect people from themselves. And so using those testing kind of as a dangling the carrot in front of people a little bit, and just being really clear up front with, hey, if you want to run, you got to be 70% the same. Until we're there, we're not really going to have that conversation. And then they just kind of know.
Sometimes before we switch into the upper body rehab, to that point of having somewhat hard lines in the sand of this is where I would expect or want us to be, sometimes I feel like, does it really have to be that hard line of a sand? And then I like kind of second guess myself of, all right, do they really need to be at 80%? What if all these other things are there? But I want standards, but how black and white are these standards?
Yep.
And I don't really spiral, but I have this like internal monologue with myself relatively frequently of thinking, is this going to change in a few months? And like, am I being too strict or too lax, with this individual? Do you have some of those thoughts with testing?
Oh my gosh, all the time. Yeah, I have like someone right now that comes to mind who's like rehabbing from a patellar cartilage repair, like a Macy procedure, and is 10 months out and still has a significant quad deficit. But at some point it's kind of like, let's start incorporating some ankle dominant plyos because you're at least not going to load your knee a ton. And so, yeah, like breaking my own rules of like, yeah, you're sitting at a, whatever, I think, what was she at recently? She probably has like a 35 to 40% deficit. But starting like plyos from like a shuttle standpoint, and like overground, like ankle pogos, like that kind of thing. So things that I feel like are safe but not as risky, but still like from just like a strict, I wouldn't start plyos until they're, at least X, whatever. But yeah, doing some of that. I mean, one, as long as you know that you're being safe and you know when to break the rules, you can break the rules. Two, I think there's a piece where she's not going back to playing college sports. She just wants to go back to like a CrossFit gym and be able to like run and do burpees and that kind of thing. And so just understanding that it's not going to be perfect. And, for me, kind of always going, how long am I willing to wait? Like, do I just keep her from any impact for 18 months, like until this like clears up? Like maybe, but yeah, it's tough. Yeah, I definitely get that. And that's the same thing. I mean, even in like your ACLs, right? Like if you have someone who does the biodex and they're at like a 68% limb symmetry, like are you going to withhold running and jumping if 70% is your cutoff? Maybe mentally, sometimes people just need that. And as long as you can protect the intensity and the volume of those things, they're safe to start adding in. So I'm there every week with you on that.
Yeah, Mark and I have done an ACL series on YouTube and on the podcast. And the thing that gives, we talked about this, I think in a previous episode, some, I don't know, clarity or maybe not clarity, but like if you look at these different protocols, whether it's Delaware or Aspetar or Vold, whatever, there's kind of different like return to running criteria. And each one's just a little bit different, like 70% versus 80% versus torque to body weight, whatever it is. And I'm like, all right, all these organizations are kind of considered like top tier and elite, but they kind of have a little bit of a wiggle room. Maybe I have some like bare minimums, and maybe I have some like this would be ideal, but you have maybe a wider spectrum than you may think as this pure black and white number. And to your point, depending on what they really want to get back to, that could change things. I've had some conversations with individuals where it isn't high level sport, but they want to return back to jogging, and maybe they're not at the level I want. They say, ideally, this is where I think we should be at. However, I don't think it's the end of the world if we try a little bit of jogging, see how your knee responds, see how you feel. And if you're not ready, then that's okay. Are you wanting to try that, or do you think we should give it another few months, and maybe giving the onus on the person if you feel like there's not a major risk of experimenting with something that is going to be a major detriment to their overall rehab?
Yeah, for sure. It kind of goes back to that conversation that I know Quinn Hinnock has had multiple times, just around like informed consent. And that's like ultimately what that is, right? Is going to the patient being like, hey, here's where you're at. Here's where I would prefer you to be. But if you're in a place where you're itching to start running and like mentally that's going to be like a really good thing for you, like as long as you know that we might run into some pain, we might run into some swelling, like we can try it or we can wait. Like what would you like to do? And I think as long as people are informed that like, hey, we can start doing these things, but you might have some symptoms, and they kind of sign off on that, then you as a clinician, you still need to be smart and don't go like crazy with it. But yeah, giving them some autonomy over those things. So ultimately it is their body and it is their knee or their shoulder or whatever we're rehabbing. And, sometimes I think we forget, like for someone who really enjoys running, like just getting back into some like interval, low level jog can like, man, that can just do wonders for someone's like mental health and for their engagement in rehab. And some people just need a little bit of a piece of a light at the end of the tunnel, if you will.
Let's transition to upper body rehab. So we touched on a variety of things to consider, a variety of movements to factor in that are likely going to be in most rehabs for the lower body. What about the upper body?
Yeah. Upper body. So, for me, we'll keep it really simple. Horizontal push and pull, vertical press and pull, and then your carry. Like those are going to be the 5 types of movements that I'm always going to come back to. And then similar with the lower body, right? You want, your bilateral, unilateral. Asymmetrical is probably a little bit less common in the upper body for me, but I'll throw it in there just for kicks and giggles. Again, all planes of movement. So much of the upper body is not just in the sagittal plane, I guess, unless you're really just weightlifting. But from a sports standpoint, obviously there's a lot of transverse plane as well. And then I think the other thing that I would keep in mind here, along with like your isolated tissue work that we kind of talked about for the lower extremity, is the upper body is naturally an open chain thing, right? Like the lower body is always weight bearing. There's not ever really a moment where someone is doing an open chain task other than maybe like kicking a soccer ball. But with the upper extremity, all your throwers, they're throwing an implement and they're getting a lot of traction or distraction through that arm, whether that's at the elbow or the shoulder or the wrist, compared to maybe like your gymnasts where they're getting a lot of like compression loads as they're like throwing certain tasks right on the mats. And so also going through like the lens of compression versus distraction and figuring out what do I need to protect them from here and what do I need to expose them to based on their sport or their activity. So those are a few things that come to mind. As far as like the isolated tissue buckets, I'll go through maybe like a few examples similar to the upper body, but um, for right your UCL, right, we're talking medial elbow, and so maybe we need to hit some like isolated wrist flexion work. If we're talking with someone that has tennis elbow, whether that's from tennis or just some kind of lateral elbow pain, maybe it's more wrist extensor work. Obviously, a rotator cuff after a cuff repair or cuff tendinopathy, etc. And you could follow that same pattern for really any tissue injury. If they had a biceps tear or a biceps tenotomy, tenodesis, they probably need some bicep specific work once it's safe to do so. And then just like special considerations for like the UCL, right? We're going to avoid like that valgus load early on. That's like one of my favorite kind of assignments to take like students and residents through, is like looking at a protocol after surgery and just like asking them, does this make sense? Why these precautions are in place? Because I think if you can't answer that, then you need to go back to the drawing board and either figure out, does this make sense from a tissue healing standpoint, or is this kind of like a silly precaution that doesn't actually make sense, and I can maybe break that if I have the right relationship with the doctor. But with a UCL, a lot of times you will see like no valgus loading, no internal rotation for like 6 weeks or whatever. And maybe no like pushing into like full extension. So going back to the drawing board of, does this make sense? I think for UCL, avoiding valgus initially makes perfect sense. And then we're going to gradually load it. We're going to gradually get them on a throwing program where they're increasing their velocity, their load, and exposing them to it. And I guess maybe a sidebar and kind of plug for a conversation that is adjacent to this. I had Meredith Chaput on my podcast very, very early on, and we kind of talked about the ACL and valgus load and why we shouldn't be scared of it. And she just made like a really good point that has stuck with me, and I try to share it when I can. But she was saying how like, isn't it crazy for like Tommy Johns, like we just gradually expose them to valgus load through a throwing program compared to like ACL. We just like try to avoid it at all costs. Like if we see valgus, we're always coaching out of it. We never want them to be, exposed to it. It's bad. But just like contrasting that with the elbow of like, no, the elbow, we very intentionally just overload the UCL so that it adapts. And why should that be any different than an ACL? That's not to say that you should just have someone do like depth drops and a lot of knee valgus all the time. That's not the point. So that's like one thing that I consider for UCL is, when do we introduce valgus? And then how do we gradually expose them to that? As far as labor repairs, right, just again, keeping in mind, where was that repair done? Was it anterior, posterior? Was it a slap tear? Was there biceps involvement? Versus like shoulder instability, same thing. Where are they getting instability? Because that can be multidirectional. That can be just only anterior, only posterior if they have a history of dislocations. And going back to the compression versus distraction types loads, and when we want to expose them to that versus maybe protect them. So those are a few things that come to mind on that.
Can you elaborate a little bit more on that compression versus distraction? I think you use distraction as like a thrower example, or compression is that weight bearing with the like gymnastics position.
Yeah.
Can you touch on those differences and how you would mediate or alternate those?
For sure. Yeah. When I think compression loads, thinking mostly like in the context of shoulder rehab, but compression, any kind of like weight bearing. So like your football, like your linemen, when they have their hands on the ground, they're getting compression through the shoulder joint posteriorly. Whenever they're making contact with other people, again, they're getting a lot of posterior shear. So they're getting compression there through the back of that shoulder, versus your quarterbacks, your baseball players, your pitchers, even like your shot put, discus, javelin, like any throwing athletes, you're not getting compression through the shoulder anymore. You're actually getting just more what I would call distraction or traction. So that shoulder joint is being pulled away from the socket, and you have to, one, expose that, but also make sure that you have appropriate like resistance to those loads. And so I think that's one thing that I keep in mind. And then with the gymnast, probably a little bit of both, honestly. Like if you're going to do a round off back handspring, you're getting some compression when you're weight bearing with your hands, overhead. But then whenever you're on the bars and you're swinging, you're getting distraction, right? You're getting that ball is pulling away from the socket. So I think just considering on a very simple, language standpoint, is the ball being pushed further into the socket or away from the socket? And what do we need to do from a rehab standpoint to address those things or expose those things?
However, or I would assume to that point, you're still introducing and progressing like those big fundamental patterns, like you talked about, horizontal and vertical pulling and pushing, carrying, weight bearing, etc., for those distraction versus compression.
Sure.
But maybe the time spent in certain activities or positions for those different archetype of athletes may be a little bit different.
Yeah, for sure. Like for my football guys that they're coming into clinic, my high school kids that maybe dislocated their shoulder posteriorly last Friday and we're seeing them this week. I'm probably not going to do like weight bearing stuff with them or bear crawls or, a horizontal push when they're supine where that load is going posteriorly through the shoulder. Maybe I'm spending my time elsewhere initially. And then, yes, eventually they need to get exposed to those loads. So that's kind of, where I consider those things.
Anything else with upper body considerations or things you wanted to touch on before we move on?
Yeah, I don't think so. I mean, I think, just on a personal note, like upper body stuff, I'm certainly still learning. I probably see like from a caseload standpoint, probably 70% lower body and 30% upper. So I've seen a smaller handful of my Tommy Johns, a smaller handful, definitely more like labral repairs has been more common. Haven't seen really any wrist. And so just from like upper extremity standpoint, that's something that I'm always trying to get better at and kind of refining my own kind of thought process and framework. It feels a little bit more cognitive than lower body for me.
Yeah, but I think to summarize both upper body and lower body, we still have these bigger buckets of these movement patterns that are likely going to be integrated into most rehabs for upper and lower. And then we can manipulate the range of motion, the tempo, the volume, the intensity, etc. And then we can add in or bias more isolated positions depending on the tissue we need to target.
Yeah, exactly.
I know you had a few other kind of final thoughts that you wrote out, but what are some kind of closing summary points and some other considerations or things you want to touch on as we round things out?
Yeah, I mean, man, this isn't something that I wrote down, but just kind of something that's on my mind as we're talking through this is like so much of this is physics. And so if this is like hard to grasp, I would actually go back to like, what are your levers? Like go back to your lever types and like consider where the center of mass is and where the external load is and how you can manipulate those things to create the adaptations that you're wanting to. Scott Morrison has been so sweet over the years to be like my physics mentor. Like I remember FaceTiming him one time and being like, I don't understand how the Spanish squat works. Like, why does it load the quad when the shin is vertical? And like, he's just like helped me walk through those types of things. And so if you get stuck, man, go back to those simple things that we learned a long time ago in school and see if that helps make it make sense. But yeah, beyond that, I would just say keep your exercise selection simple. Ryan Bogus with HQPT, he asked this or kind of posed this to me a long time ago, and it's haunted me ever since. I include it in almost every lecture that I give to our residents. But he essentially asked me, like, what adaptable training or what adaptable quality are you training? And essentially, if you can't answer that question, like go back to the drawing board, figure out what you're trying to go after. Because if you don't know what you're going after, you're probably just throwing spaghetti at the wall a little bit. And so what I mean by that, what adaptable quality, right, are you training is if we work on something, is it going to change, right? So yes, if someone's missing knee flexion, okay, we're working on knee flexion. That's the adaptable quality we're trying to change is like knee mobility. If someone is pretty strong, but they're just not quick, maybe we need to work on rate of force development. And so your dosage should reflect that. And so that would be one thing is just keep it simple, know what quality you're trying to go after. And if you don't, like that's like big self-awareness step number one is just go back to the drawing board and just ask yourself, what is the goal of the session? How can I accomplish that goal? And then two, we kind of hit on this earlier, but I would just say, like, don't be afraid to repeat the same exercise or the same exercise with small variations. I think one thing that I've learned around being around strength coaches is that they do a really good job of just sticking with the basics and doing the same thing for like 4 to 6 weeks at a time. And that's just kind of what they do. And it works. You can see numbers change. And I think that's something that we can learn a lot from strength coaches is just sticking with things and letting things change and not feel the need to have to change something every session. I know personally, like being at the clinic that I'm at, we will get patients who've gone to like your PT Mills. And like one thing that they always say that is really interesting on their end is, man, when I come here, like I do something different every time I come. And for the longest time, I was like, man, that's a huge compliment. And I would say one thing that I've reflected on is like, maybe I shouldn't change things that often. Like maybe there should be every session, maybe we're changing like one thing. But I think patients that have gone to Mills, they almost get handed their flow sheet and they can like take themselves. They're like, oh yeah, well, I just know I do these 12 exercises because I've been doing the same thing for 3 months. And like, I'm with a high school tech and like, I can pretty much take myself through the exercises. And there was a lot of me that just wanted to not be that. But in not being that, I got in the habit of just changing things all the time. And I think you could argue that you're not going to get any adaptation if you're changing things all the time. Now, I think there's caveats to that. I think now when I see people and treat people, maybe we're doing split squats for 4 weeks, but the variation changes a little bit to keep the person engaged. And so maybe the tempo is changing or where we're putting the loads changing, but like the overall the big picture is the same. So I guess just don't be afraid to repeat the same things. Like that is okay. You're not a bad PT for doing that. Strength coaches do it and it works phenomenally. So stick to the basics. And then finally, just like keep yourself honest by testing when you can. I think ignorance is bliss. I think if you never test people, it's really nice to be like, man, they're doing great. And they're doing great because you don't know how bad they're doing. And so as a clinician, don't be afraid to test people. It keeps you honest. And really, it's doing a disservice to our athletes or our patients if we're just taking a guess in the dark. So if you have the ability to test, that keeps you honest, that helps you inform your decision making. That helps you inform like your exercise prescription, right? If you notice that someone is still missing isolated quad function, like that's probably something that you need to figure out in your session, and maybe get away from doing only really, really compound movements where they have the opportunity to offload to the hip and the opposite leg and the trunk. But you wouldn't know that unless you tested it. And so, yeah, that's probably the 3 things that I'd say to round this out.
One other thing I would add, if someone has access to, hopefully they have a mentor or their group, part of a group online, or they have colleagues that they trust or fellow students, that they have kind of a program review and they outline, this is my plan of care, or this is what this session looked like, or this is what the week looked like, or the month. These are what I was trying to achieve. And then the person you're chatting with almost like picks it apart. And sometimes it can be uncomfortable or challenging to do that. But really trying to justify, this is why I implemented this. This is why I put it in this order. This is how I would progress. This is how I regressed. And people asking simple questions as to, why did you implement this versus that? What is your reasoning? You having to justify it and hopefully have a well thought out explanation for all of the things you're implementing, even if it's as simple as like, I just needed to like give someone some, spacing of like, all right, this isn't that valuable for their rehab, but I need them to take a little bit of rest. So we're going to do this other thing. Like, it doesn't have to be like the most unique explanation ever, but like justification for the flow of a session, the loading, the tempo, whatever it is. I think that's extremely helpful as well with
Absolutely.
students, colleagues, mentors that you have to kind of pick apart your decision making.
Yeah, exactly. And like, you don't have to go through a residency or fellowship to have that experience. Like you can literally I can just call you up and be like, Chris, I'm going to send you my program. Can you like give me some feedback? And really that's just, if you can ask someone why enough times, that's like the most helpful thing. It doesn't have to be you don't have to feel like you provide really great mentorship. Like just ask people, why did you do this? Why did you progress this way? How did you know they were ready for these things? Just make people think. And yeah, that's a beautiful way to be a mentor to a peer.
Totally. All right, Shelbie, we will call it there. I think this was a great discussion. I'll link your information below and how people can listen to your own podcast, learn more, and reach out if they want to. Thanks again. We'll call it there.